Afternoon and good evening. Thank you all so much for joining. My name is Dr. Amanda McClelland. I have the pleasure of welcoming you all to this special panel discussion, which is part of a series of events celebrating 10 years of activities and impacts made possible by the Ohio State University Global One Health Initiative and its partners. In addition to my role as a faculty member in the College of Veterinary Medicine at Ohio State University, I also serve as the Director of Outreach and Engagement for GoHi. So to learn more about our upcoming events, including our formal closing ceremony on November 4th, which is in honor of One Health Day, I want to encourage everyone to visit our website at go.osu.edu/GoHi10. I could put that information in the chat box to register for our upcoming events. We are excited to be celebrating this important milestone with a global audience, and we thank you so much for joining us. The panel discussion today, which is focused on the future funding landscape for Global One Health activities, will be moderated by the current and founding Executive Director of the Global One Health Initiative, Dr. Wondwossen Gebreyes. Dr. Gebreyes, the floor is yours.
Great. Thank you so much, Dr. Berian. Good morning, good afternoon, good evening, all of you. My name is Juan De San Gabrieles. I am a professor of molecular epidemiology with background in veterinary medicine. I also serve as the executive director of Global One Health Initiative at Ohio State, which includes really broadly throughout the university with 13 colleges involved, many of them from health sciences, agriculture, business, engineering, education, social sciences, and many others. So thank you all so much for being here with us as we continue to celebrate our 10th anniversary of the Global One Health Initiative's activities since about 2012. Let me also add that currently, I'm expected to make this disclaimer and inform, currently I am a fellow of the American Council on Education. My host university is Michigan State University. Currently, I'm working with President Samuel Stanley and his other leadership provost, as well as the Executive Vice President for Health Sciences. So I'm currently in East Lansing, another wonderful university, comprehensive land grant university, similar to Ohio State. So I'm very delighted to be a fellow working here at MSU this academic year. Let me start, of course, by thanking all our panelists and all of you joining us today for this series. And really GoHi, I think many of you, I hope you already know Global One Health Initiative, but in the audience who might be new, Global One Health Initiative is committed to continue its impactful work globally. It's not just international, but starting from Ohio in the backyards of the state of Ohio as land grant universities, with fulfilling our vision of building capable institutional systems and with goal of saving lives and improving livelihoods globally, local, regional, national, and international. Indeed, our focus is on the interface of human health, animal health, plants, and our collective shared environment. So it's my distinguished pleasure to hosting today's panel session. This panel, as you can see, is composed of diverse, in many different regards, diverse organizations from federal and foundations, diverse and multidisciplinary team, physicians, nutrition and global experts, as well as a nurse. Really, I'm delighted to be with all of you, and I'm myself a veterinarian, really a true, among 5 of us, you can see a true One Health group. So before I start introducing each one, let me start again by really thanking beyond the panelists the organizations they represent. Each of these organizations have been instrumental working with our Global One Health Initiative and enabling us to fulfill our mission and our vision. And without these organizations, of course, it would have been impossible to celebrate the first anniversary of GoHi, I would say. Some of you started back in 2010, even prior to 2012, like NIH, working with NIH for a long time. all the way to more recent partners like Resolve to Save Lives. Amanda, very thankful, especially right on COVID hit, we started working Resolve to Save Lives. So I will come back giving you a little bit of introduction on that, but let me introduce each of the panelists now. The first list I have is Dr. Peter Kilmarx, Deputy Director of National Institutes of Health, Fogarty International Center. Peter is a physician, scientist, and expert in global health and infectious disease research, policy, and programs. In his current role as a Deputy Director of this, Fogarty is our key and very long-term flagship partner for us. It's a preeminent center for global health research and capacity building, which is very much at the core of our Global One Health Initiative's efforts. He previously served as a country director in Zimbabwe and in Botswana for the US Center for Disease Control and Prevention, and as a chief of CDC's Sexual Transmission Research Section in Thailand. A retired Assistant Surgeon General, and a Rear Admiral in the US Public Health Service. Dr. Kilmarx served in leadership roles in CDC's Ebola response efforts in Guinea, Sierra Leone, and Democratic Republic of Congo. As you all know how important Ebola is in the context of One Health as well. After his MD, he completed his internal medicine residency and infectious disease clinical fellowship at Johns Hopkins Hospital, Baltimore, maintaining board certification in both specialties. His international career began as a Peace Corps volunteer in DRC, which he went back to Ebola, but a long time ago. At that time, it's called Zaire, where he helped develop fisheries that are still productive today. That's wonderful to hear that, and did not know this part of your bio, Peter, and thank you and welcome. Please join me welcoming Peter virtually, however we do it. But, great to have you again, Peter. Next is Kristen MacNaughtan. Kristen is a program officer, nutritious food systems, agriculture development at Bill and Melinda Gates Foundation. We have been working with Kristen and other program officers for the last more than 5 years. She's currently as a program officer and is in this area, as just mentioned, where she builds teams and grants to tackle complex multi-sectoral challenges with a portfolio seeking to improve nutrition, health, and women's empowerment outcomes. She designs and manages agricultural, livestock, and food systems programs, concentrating on supply chains, market systems, foodborne disease, food safety, and so on and so on, policy, but and so on and so forth. The childhood stunting and many other highly important peripheral issues in developing regions. So Kristen leads highly important portfolio. Prior to joining Gates Foundation, Kristen worked on both private and non-profit sectors. She holds a Master of Science in International Development with a focus on public health and nutrition from Tulane University. So welcome, Kristen, and thank you so much. Great to having you. And special thank you for Kristen. Remember, she's in West Coast in Seattle. It is 5:30, so early morning. So thank you so much, Kristen, for that as well. Will not be very hard on you on questioning you and such early morning. Next is Dr. Ermias Belay. He is the acting director, currently Division of Global Health Protection at the Center for Global Health and at CDC, Centers for Disease Control and Prevention. Dr. Ermias Belay first joined CDC as an Epidemiologic Intelligence Service EIS officer in 1994. And over the years has served in various positions at CDC focusing on infectious diseases. He is currently Associate Director of Epidemiology, until very recently is Associate Director of Epidemiology Global Health in Division of High Consequence Pathogens and Pathology, DACVPM. We have worked with Ermias as Go-High for a long time. Ermias and the CDC DHC Division of High Consequence Pathogens and Pathology team since about 2013, and recently he assumed the acting director role at Global Health Protection. So congratulations is in order, Ermias. the National Center for Emerging Zoonotic Infectious Diseases, which now is slightly different center, but sister center within the CDC. In this role, in the zoonotic and infectious disease role, he coordinates the global health activities of the division, including programs and projects in many countries focusing on Ebola and other emerging hemorrhagic fever viruses, orthopox viruses, rabies, brucellosis, anthrax, some of them bacterial, of course, and other zoonotic pathogens. He provides epidemiology oversight across the division, which consists of diverse programs ranging from bacterial and viral zoonotic diseases, infectious disease pathology, prion diseases, chronic fatigue, and emergency preparedness for several tier 1 pathogens. In fact, the first time I saw Ermias speak, I remember maybe back in around 2002 at Atlanta ICEID meeting, which was talking about prion disease, mad cow disease, as many of us, many of you in the United States remember, in the mid to late 1990s, were a major issue of CJD. And I remember a wonderful talk Ermias gave in CDC's investigations that he led. Dr. Belay also supervises neuroepidemiology programs that provide CDC-wide support of investigating the neurology complications of infectious disease outbreaks, CDC emergency response, currently COVID-19 response, Zika virus-associated Guillain-Barré syndrome in Colombia and Brazil, in Ebola epidemic in Sierra Leone, 2010-11, Haiti cholera response, H1N1 2009 influenza response. He has served in several advisory committees at FDA and HHS. Is currently is an associate editor of the Emerging Infectious Disease Journal. We all read and appreciate greatly. So thank you, Ermias, and welcome to this panel again. Last but not least, Amanda McClelland, Senior Vice President at Resolve to Save Lives of the Vital Strategies. Amanda McClelland is a registered nurse and currently serving at such a high-level role and very important role, resolving issues and preventing epidemics in this organization. She leads a team working to accelerate progress to make the world safer from epidemics. Her achievements include coordinating frontline Ebola response during the 2014 Ebola epidemic, for which she receives the 2015 Florence Nightingale Medal, wonderful news, and for exceptional courage. Prior to joining Vital Strategies, Amanda served as a global emergency health advisor for the International Federation of Red Cross and Red Crescent, IFRC. So thank you so much, Amanda. Welcome. As all of you realize, we have such a distinguished multidisciplinary team. It's amazing to see 3 of you have worked in Ebola response, which is really a very important issue and topic for us today and all the time, and besides COVID and many other issues that we deal with globally today. So the organizations these panels represent have been highly valued financial as well as technical resource partners for us for GOHI. So I really want to take the opportunity today to really thank you and thank the organizations. And let me highlight a few points before I let the floor to Peter. The GOHI's trajectory as we accelerate, without these organizations, as I already said it, it wouldn't have been possible. So just to highlight a few things. With NIH Fogarty International Center, the first program grant we received was 2010. We were not even, GOHI was not even quite established. But as a PI myself, and from 4 colleges, multidisciplinary partners, as well as from Kenya, co-PI from the KEMRI. I'm sorry, my light might go up and down, sorry. From Kenya Medical Research Institute, as well as Ethiopia and Tanzania. That program is still active through 2023. We trained 28 PhD fellows, more than 2,900 short term through Summer Institute. Highly impactful work, even beyond the 3 countries. And many of those 28 PhD fellows are currently working at their respective institutes in COVID-19 diagnostic systems. Our focus is molecular epidemiology, and there, the tools they learned, PCR, genomic sequencing, others are highly useful in COVID-19 response. So Thank you, Peter, and all NIH Fogarty team, Roger, and all the program officers at NIH broadly, but particularly Fogarty International Center. The CDC partnership has kept flourishing since 2013, when Dr. Ermias, myself, and the team of Ohio State CDC partners launched a model project, a model Oneness project using a classical disease, rabies. Our goal is impacting on rabies, which still kills large number of children in sub-Saharan Africa and many developing countries, but also using that as a model for future pandemics or large epidemics. And as you know, of course, we are in the midst of COVID-19, and we hope the model we created, connecting these various stakeholders in the Ethiopia as a country model, has enabled in COVID-19 efforts. That project has led to Global Health Security Cooperative Agreement, which we still very actively work with CDC and Ethiopian government, enabled mass vaccination of more than 100,000 dogs, large number of surveillance officers trained, brucellosis surveillance in many parts of the country launched, and capacity built throughout. This is also building the capacity of the professionals and increasingly working also on antimicrobial resistance and antibiotic stewardship in networks of hospitals, but which we hope in the near future to expand into animal-human interface besides the hospital. So thank you, Ermias, and all the Center for Global Health, as well as Center for Zoonotic Infectious Disease team of partners. It was also absolutely great pleasure to work with Bill and Melinda Gates Foundation in multiple projects for the past more than 5 years. Particularly one I want to highlight, we have embarked on childhood stunting and its relationship with exposure of children with backyard poultry. Typically, in an average, when I grew up, I was an urban farmer in Ethiopia, Addis Ababa. When I was a kid, I had children. I know how to be a backyard farmer in the capital city of 4 million people. Children's exposure to backyard poultry and focusing on using one of the model leading bacterial foodborne pathogen, Campylobacter. And it's a collaborative effort. It's led by University of Florida, Ari Havelar, to recognize that, but Ohio State has been very delighted to partner in this highly important project because we believe the hypothesis is this exposure to Campylobacter through the poultry will result in childhood stunting, environmental enteric dysfunction. Other projects we do, a growing project on foodborne pathogens in multiple organisms is a great project led by Ohio State GOHI members, and more recently also on curriculum twinning areas, which in fact Dr. Amanda McClelland is a principal investigator. So we're very thankful to Bill and Melinda Gates Foundation, to you, Kristen, and other leaders for this growing partnership. Last but not least, soon after the COVID-19 pandemic began in late 2019, but even before it was designated as pandemic in early 2020, resolved to save lives. And the key leader, Amanda, landed in Ethiopia, and together with our regional director, Dr. Getmet Yimar, they launched a highly important COVID-19 project focusing on the public health social measures. As you all know, often once outbreak, epidemic, or a pandemic happens, often we tend to focus on the mitigation efforts and the pharmaceutical parts, vaccination or diagnostics and others. But they focused on the non-pharmaceutical intervention aspects, these public health social measures, which One Health should and can play a critical role for this pandemic and, God forbid, for future ones. So this is a very important work we do. We highly value that work. I believe more than 730 households from 4 major cities and towns of Ethiopia were included. We learned a great deal from it. Our team, together with Amanda's team, advised the Minister of Health to take measures to minimize the damage from the pandemic, which I hope it occurred. That is, again, the role of the government to do. Similar work is done, I'm aware, in multiple African countries, together with African CDC, Resolve to Save Lives, and other partners. And we continued our partnership further in developing other qualitative studies in COVID-19. and so on. So look forward to working more with Resolve to Save Lives and with all of you. So thank you, Amanda, and all the key leaders at Vital Strategies. So thank you so much. So this is my, I just want to make sure the audience and everybody under, even though the program officers and as we know that what we are doing already, but I would like to share this, how delighted we are, humbled as Global Oneness initiatives that you all are our wonderful partners, and we look forward for the future. So I might have taken a bit too long than Dr. Berian allowed me to do, but I will leave the floor to the first panelist now, to Dr. Peter Kilmarx. So Peter, why don't you go ahead and share your screen?
Wonderful. Thank you very much, Wondwossen. Just want to also congratulate you on being elected a member of the National Academy of Medicine. What a great recognition for you. And we're very much looking forward to having you come onto our board at the Fogarty International Center.
Thank you.
I'll go ahead and share my screen. Can you see and hear me well enough?
Yes, we see it, we hear you very well.
Good, thanks. So really delighted to be here and talk about the future funding landscape for global health research from our perspective from the Fogarty International Center. And just a quick background on the NIH as the steward of global medical and behavioral research. It's a two-part mission for the NIH. The first is about the basic research and seeking fundamental knowledge. And then the second part of the NIH mission is the application of that knowledge to enhance health. There's 27 institutes and centers with a budget last year of $43 billion. And there's a very strong commitment to global research from the NIH. We see unique scientific opportunities, especially infectious diseases, but also in genomics, environmental exposures, and other areas. There's more than 12,000 active international collaborations supported by NIH. And we did an analysis a couple of years ago and found that a whopping 35% of NIH-funded publications had a non-US affiliated co-author. So we really see it as a global enterprise. At the Fogarty International Center, we support NIH's global partnerships. And then with our funding, we strengthen capacity in developing countries and train the next generation of scientists. There's over 6,000 that have been trained worldwide, more than 400 ongoing research and training projects with over 100 academic institutions. It's very diverse. It's not just tropical medicine and infectious diseases. It also includes non-communicable diseases and work in environmental health, bioethics, mHealth, implementation science, and other areas. So very timely for the question that Wondwossen asked us to address, the Fogarty director, Dr. Roger Glass, and I recently published in PLOS Medicine a paper on building global health research capacity to address research imperatives following the COVID-19 pandemic. And we really emphasized that COVID-19's provided a great example of the importance of health research capacity as an essential element of pandemic preparedness. We see building research capacity must become a higher priority to achieve our shared global health goals and increasing resilience to future health threats. We also wrote about how COVID-19 is recalibrating our perspectives of the levels of expertise among higher and lower income countries. And in the global north, we need to bring a new sense of humility and equity to understand all the lessons learned and improve global health following COVID-19. This was part of a special collection, PLOS special collection about how COVID-19 is transforming global health, which I would encourage you to take a look at. So we do see great challenges and also great opportunities in global infectious disease research. There's been an unprecedented response to COVID-19. We now have home rapid self-tests, improved survival and treatments, and a selection of approved and effective vaccines, but really also a great unfinished agenda in COVID research. Much of that will be international. We're really learning a lot in terms of vaccine effectiveness and other questions from international collaborations, not just from within the US. And again, has underscored the importance of research capacity as an element of preparedness. Where there's disparity in research capacity, there's delays in medical countermeasure R&D, as we saw with Ebola in West Africa, and the delays in getting the treatment and vaccine trials off the ground in West Africa. So in our paper, Roger and I highlighted priority areas for future research and did underscore One Health as one of those priorities, and looking at the interconnections between humans, animals, plants, and the environment. And the transdisciplinary approach is typical of what we support from Fogarty. Also, planetary health, looking at the health impacts of climate change, declining biodiversity, increasing pollution, and shortages of freshwater, land, and ocean resources. This is getting a boost from the current administration with funding for climate change and health research. I'll say more about that in a second. And then implementation research has been a longstanding priority for Fogarty in promoting the uptake of evidence-based interventions and policies. For seizing these opportunities and meeting the challenges, again, we emphasize strengthening research capacity in low and middle income countries. From Fogarty, we focus primarily on human capacity and training, and see the need to provide protected time for research with international mentorship and networking. I've been working on funder coordination using metrics to improve the efficiency and equity of research capacity building and engaging the national stakeholders on their priorities, as well as pandemic preparedness. This has been work done with the Essence Forum of Funders of Health Research Capacity Building. And I'm pleased to see this approach of using metrics to improve research capacities being taken up by the Global Preparedness Monitoring Board, and also the Global Health Security Agenda that recently launched an R&D task force. We having a webinar coming up week after next, and the link is here. We'll share these slides and you can click the link, and we would encourage you to join this webinar about increasing effectiveness and equity in strengthening health research capacity using data and metrics. Also with COVID-19, we've seen the increasing use of digital platforms, global collaboration, and rapid publishing, and many best practices that we think will continue in the post-COVID era. Also seeing the importance of addressing the infodemic of misinformation and disinformation with the research agenda around that. Just on the work that we're doing on metrics of research capacity, just using some simple measures such as numbers of publications or numbers of clinical trials, we can make a map and see where the capacity is strong, but also where there's holes in the map and where we need to bring more attention and resources to bear to strengthen research capacity as an element of pandemic preparedness. Just to mention some individual training opportunities from Fogarty. This is a picture of our director, Dr. Glass. We have the Global Health Fellows and Scholars program where students and postdocs can get support to both US and LMIC fellows and scholars to have supported research for up to 12 months. We also have a K Award, the International Research Scientist Development Award for US postdocs for up to 5 years. And then relatively new, we have also a K Award for LMIC research scientists, the Emerging Global Leader Award, similar to the K01 for US scientists, but this is for researchers, early career researchers from low and middle income countries. Some really now emerging opportunities for global health research I can mention in climate change and health. The White House, the House, and the Senate budgets have all called for $100 million for NIH research on climate change and health. These funds are directed to the National Institute for Environmental Health Sciences, but there is a global research is prominent on the agenda, and Fogarty co-chairs the NIH-wide working group in this area. There's also new funding likely coming. It's in all of the budgets so far for FY22, a $10 million increase for Fogarty to support additional research related to health disparities. And this would include, including in infectious diseases and in One Health, so it would be relevant to this audience. And then lastly here, there's a proposal and potential funding for an ARPA-H, an Advanced Research Projects Agency for Health. And this would call for creation of a new program that would drive transformational innovation in health research and speed implementation of health breakthroughs. And at a listening session, the NIH leadership emphasized the importance of global partnerships as part of this. And so, for example, one can imagine, like we had RADx for rapid development of point-of-care testing for COVID-19, we could have a kind of a RADx for neglected tropical diseases, for example, might fit in. That's been talked about as something that would fit in to an ARPA-H activity. I was also asked to talk about our engagement with the African Union and other initiatives to increase African investment in research and development. So we are part of what's called the Coalition for African Research and Innovation, or CARI. And this is NIH with the Gates Foundation and the Wellcome Trust, working with the African Academy of Sciences, the African Union Development Agency, NEPAD, to advocate for increased investment from African governments and the private sector. There's a link here to an article by Dr. Glass about this. And then also a recent webinar there in the lower right corner about African Investment Summit on Health, where Dr. Glass joined with health, business, and development leaders about increasing the investment. And then the link in the middle there is about coming from IUTA NEPAD, talking about harnessing innovation and emerging technologies to address the impact of COVID-19 in Africa, with discussion about the ASTIF, the African Education, Science, Technology, and Innovation Fund. Just want to mention resource worldreport.nih.gov. This is where we actually map the grants and indirectly funded collaborations from NIH, but also over a dozen other funders, such as the Medical Research Council, the European Union, the Gates Foundation, the Wellcome Trust. So you can look up and see who's doing what where, whether it's the examples here around One Health or malaria. You can help find who's funding what and who the researchers are. Lastly, just want to encourage you to join us, follow us on social media at Fogarty. We've got a funding newsletter that comes out every week that has funding opportunities from NIH, but also from other funders, and then also on other social media. So I'll stop here and look forward to the rest of the discussion. Thank you.
Excellent. Thank you so much, Peter. Wonderful overview and highly useful information, both in the funding context as well as resources such as the Wondwossen report. It's very useful. So we'll come back for discussion soon, but very much appreciate your remarks. So we'll move on to Kristen MacNaughtan. Kristen, if you make your remarks.
Let me just share my screen.
Okay, go ahead, please.
Let's see here. Can you see that okay?
Yes, we can see that. Perfect. Yeah, very good. Go ahead.
Thanks so much for inviting me today. It's been a real privilege already so far to hear about your history, Wondwossen, and also to hear about all the work at the NIH. Ohio State University actually sparked our first real One Health investment back in 2012 when we ran a One Health Grant Challenge with Dr. Lonnie King, a former dean here at OSU. And it's been fantastic to see the impact OSU and Go High have had since then as a leading advocate for One Health, as well as the deep work around institutional strengthening and capacity building, and of course the technical work, and really how it's changed the field to move toward this collaborative way of working. So at the foundation, we believe that everyone deserves the chance to live a healthy and productive life. And baked into this is both a call for well-being linked to lifelong health, as well as realizing economic opportunities. And livestock, of course, plays a central role to both, with about 60% of the population living with under $2 a day owning livestock, which serve as critical assets, safety nets, insurance, as well as food and nutrition and income. But the burden of animal diseases for animals, as well as for people, and the economic burden, as well as the health burden, is real. And so across our global divisions at the foundation, which span global health, global development, and global growth and opportunity, we work on shared issues touching animals and people. It's both the what we invest in, but also really in the how we work cross-functionally to design programs and grants to tackle some of these issues cross-sectorally. We are very lucky to have a pool of expertise we can pull together to consider these issues from the perspective of global health, public health, and animal health. For our agriculture team, where I sit, it became clear back in 2011 when we were refreshing our strategy that if we wanted to make a difference for agriculture and nutrition, we really had to prioritize animal health and animal systems in addition to animal production. So about 20% of our ag budget, which is about 400 million a year, so about 80 million a year for livestock, goes to helping animals stay alive and be healthy and productive so that people in turn can be healthy, nourished, and productive. In animal health, for example, we invest in discovery science for things like vaccines and biologicals, drugs, diagnostics, and also in product development, registration and delivery for about 14 priority diseases. And this includes zoonoses like bovine TB, and crosses into our global health program where they also have a deep focus on human TB, but obviously, you can't solve for human TB without backwards linking and thinking about bovine TB. In animal systems, we support the strengthening of veterinary services in both their public and private components. We strongly believe that protecting animal health and welfare can improve human health as well as food safety and nutrition security. And then there are portfolios like mine, which is nutritious food systems, and Wondwossen talked a little bit about the way we focus, which seeks health and nutrition outcomes delivered through the agri-food system. So we look at both positive ways to improve nutrition, like improving consumption of animal source foods, which have the essential micronutrients often in short supply in the diets of marginalized populations, as well as mitigating potential harm to nutrition and health that can come from that close shared environment by animals and people, where sanitation and hygiene and veterinary care are lacking. So when you look at data like this, which comes from the 2015 WHO FERG report, you can see that it's the foods that are amongst the most nutrient rich, the ones that we want to promote for a healthy, diverse diet. The animal source foods, the fruits and vegetables, they're often the most contaminated with foodborne pathogens, which put people at risk for getting sick. And then if you look at what they're contaminated with, you can see why it's so important for us from a nutrition perspective to consider that animal-human interaction within the food system, and link across sector to do something about it. So when we look at the issues in the systems way, both for opportunities as well as the threats for what might prevent us from meeting our desired outcome, my team is essentially Velcroed to the livestock team as we collectively work to improve access to and affordability of animal source foods, but also as we work to improve food safety, reduce the risk of foodborne diseases, and also the spread of biological pathogens. And then, on ag, for my team and the livestock team, we stay in close contact with the other teams outside of agriculture. We share priorities and approaches and coordinate and co-plan our work, particularly with teams in our global health division, working on issues like enteric and diarrheal diseases, the relevant infectious diseases that span our joint interests, and the systems and services jointly needed to realize our higher level goals. we see a pretty solid overlap in the Venn diagram of what we do. And of course, the pandemic has heightened all of this, deepening our cross-functional connections as we seek to build off one another's work. That's a little bit about, that kind of internal how we work and what motivates us to come together. And I'll just talk a little bit about sort of some of the what that we invest in, sharing a few examples that are representative of the types of work that we fund within that Venn diagram, which really at its center is One Health with its multi-sectoral, multi-systems issues. We invest in data and evidence. We have a couple investments with the OIE, the World Animal Health Information System, or WAHIS, and also the Global Burden of Animal Diseases. We invest in these to improve global animal health data and the economic impact of animal diseases to inform decision-making and resource prioritization for effective prevention and control of animal diseases, including zoonoses. And then linking to food safety, we're investing in understanding transmission dynamics of zoonotic and foodborne diseases from farm to fork, and the levels of contamination in certain foods. We're investing to understand the cost of illness attributable to certain pathogens transmitted through food, as well as the environments where animals and people frequently share space throughout the food system. Biological pathogens like Campylobacter, Salmonella, the key E. coli, Brucella, and others. As Wondwossen mentioned, OSU and the Global One Health Institute are key partners of mine in this work, both as lead grantees and also as important sub-grantees across our portfolio looking at foodborne disease. And then as an example of some of the cross-functional work, Wondwossen mentioned some specific work we have in Campylobacter led by University of Florida. But we also, in 2018, together with our enteric and diarrheal disease team, and in close consultation with the livestock team, my team ran a grand challenge looking for novel research on Campylobacter transmission dynamics in complex, low-income country settings. It's an important pathogen for enteric outcomes and for livestock health and productivity and for nutrition and food safety. So it made sense for us to all come together and design a common approach and set of questions to guide our research investments. So that's just one example of that way that we come together to work. We invest in systems and governance and capacity. Also with the OIE, we invest in veterinary health to enhance performance of veterinary services in sub-Saharan Africa and South Asia to improve prevention and control of animal diseases. We support the African Union's work on food safety, which started maybe, 10, 15 years ago, focusing on aflatoxins specifically, but also has expanded in recent years to take a comprehensive approach to food safety. It's been exciting to see the African Union out in front, leading around measurement and metrics linked to food safety at the continental level. They've developed the first holistic food safety index comprising markers of health and systems and trade impacts. And the AU has also advanced work to stand up an African food safety agency to coordinate and elevate food safety mitigation efforts across the continent. And that effort is led by the rural development teams within the African Union. We also support the African Union through the African CDC and the Pathogen Genomics Institute there. We support the institutional strengthening for labs and surveillance of priority infectious diseases. And we're quite excited to be working with Go High on an upcoming Grand Challenge side event to advance conversations around shared systems and services for diagnostics and surveillance of diseases touching global and public health, including foodborne disease, and really bringing those systems and those conversations together to build a stronger whole. We invest in tools and technologies like vaccines to control disease in animals and to protect people against zoonotic infection. This summer, we announced funding with the UK's FCDO and BBSRC for a new animal vaccine manufacturing innovation center at Purebright. The goal of this investment is to prevent future pandemics by accelerating the development and delivery of vaccines to stop diseases at their source before they become a threat to people. So that's just a few examples of what we fund that we hope will have impacts across global public and animal health outcomes. And so, to the question of what now, what next, the future is clearly together. The heavy lifting around One Health has come from vets and the livestock sector, but the pandemic has really captured the attention of the global health community and generated momentum like we haven't seen before. So it's also made clear to all of us, not just scientists and modelers, the economic and social costs of inaction and prevention. Drawing a parallel from nutrition, there was really a sea change when economists joined the call for investment in improving nutrition. It wasn't just the right thing to do for people's well-being, but it became a necessary input to GDP growth. And I think we're seeing some of that here regarding infectious diseases now, particularly zoonotic diseases. So we really need to leverage this momentum and interest to keep the pressure on. Without taking the systems approach to understanding, diagnosing, surveillance, we'll miss the root causes and we won't advance the agenda that we collectively want to see borne out linked to global health security, well-nourished populations, and economic prosperity. I've listed a few areas here on this slide that we'll continue to lean into across our divisions and across our shared interest for public health and animal health and global health. We're also very excited to see the One Health agenda advance prominently within the UN through things like the UN partnership across OIE, WHO, FAO, together with UNEP for One Health, as well as cross-institutional collaborations and coordination from WHO, FAO, WTO, and the African Union for food safety and foodborne disease. We're supportive of this work and watching it very closely. We're also excited to see governments like the UK newly prioritize One Health, adding to others like the Germans who've been longtime investors in this cross-sectoral space. So funding is certainly trending to more joined ways of working. And it will be voices like GoHi that can keep the pressure on and help the global health community think through what they need to do to create that stronger holistic system. I personally find this a very exciting time. And I'll end on that note and turn it back to you, Wondwossen. And thanks again for the opportunity to share a little bit about our work and our thinking in this space.
Excellent. Thank you so much, Kristen, and indeed Gates Foundation as a whole. As you all have heard from NIH and the Gates Foundation, these two are the largest funders of global health, and the trend to see in both panelists towards one that is highly needed for the planet because it deals with interface, and often we see a very tricky situation. I myself as a professor, when we apply for grants long time ago, for example, MRSA, medicine-resistant staph aureus in pigs was a problem in Europe. We wanted to do work in the US. When we apply to USDA, Department of Agriculture, thinks, oh, this is more of a public health NIH issue. When you submit applications to NIH, I remember that NIID, and it was, I don't think even it was scored, we get a response saying that this is more of animal issue. So this interface falls into the cracks, but it's great to see this wonderful progress. Our federal government, as well as foundations like Gates Foundation, these two are the two of the largest in the world, and seeing the evolution of, and hearing from Kristen, the Gates Foundation's evolution into the dimension of One Health. So that's so wonderful. As Kristen said, yes, we will be co-hosting food safety and whole genome sequencing in Africa, for example. That's many projects I'm sure in the future Gates Foundation will embrace. I also want to make my personal point in terms of Gates Foundation, something that came to my mind in 2016, the Grand Challenges meeting was in London. I was honored and happy to be invited to Grand Challenges quite a few times every year since. At that meeting, at the closing, often Mr. Bill Gates comes and gives a speech, and often you hear global as HIV is all over the map and TB is all over. But at that talk, I mentioned it to some people, I was very happy to hear Bill Gates mentioning brucellosis and the interest in animal health. And this is really One Health, so not a disease issue. And clearly, Gates Foundation showed its commitment as incrementally as Kristen mentioned. So thank you so much, Kristen. So we'll move on to CDC, Dr. Ermias Belay. So we'll come back to you, Kristen, Peter. Great, yeah. So make it presentation mode. Ermias, you're muted.
Okay, I finally succeeded in unmuting myself. So Wondwossen, could you confirm if you could see my slides?
We can see it, but make it a presentation mode. Yeah, right, yes. We can hear you, we can see it, just make it that.
Right. This is not visible, Wondwossen?
It is visible, but not in presentation mode. So if you click where you're, yeah.
Is that better?
For some reason, the slide got smaller. In fact, this time, maybe go back to the other view. I'm sorry. Yeah.
I think this might be better.
Perfect. Yeah, go ahead, please.
That's okay.
Thank you.
Thank you, Wondwossen. Congratulations to your induction in the National Academies of Medicine. And I'd also like to thank the Ohio State community and Go High for your 10 years anniversary. This is a big achievement. As Wondwossen was saying, we have a lot of projects that we've been working with Go High, and Go High has been an extremely valued partner in some of the work that we do. As you may be aware, CDC has a long-standing engagement in global health, and we have the Center for Global Health that coordinates CDC's global engagement. There are very specific projects that a lot of people are aware of, including PEPFAR, focus on HIV, global immunizations, the President's Malaria Initiative, in other large projects that CDC has been working on for many, many years. But what's relevant to the work that Go High has been doing is the global health security. So my talk will focus on understanding and describing global security a little bit better, including what is in the future of global health security. Now, to better understand global security, I think it's important to briefly describe the international health regulations. As you may know, the international health regulations is a legal instrument that mandates countries across the world to quickly notify WHO about diseases that have a potential to spread globally. This is intended to prevent diseases from spreading across international borders, and it also outlines minimum requirements for countries to have so that they'll be able to detect and respond to the disease outbreaks. In the regulations are ratified by WHO member countries. And as I say, it's a mandate. It's a legal mandate that they report usually within 2 to 3 days of any potential problem that could spread globally to WHO. Now, there are core capacities that a country should have and establish and also maintain to be able to meet the IHR requirements. And those core capacities on where the countries stand is annually reported to WHO. Now, before global security came into existence about 5-6 years ago, 2 out of 3 countries did not meet the minimum IHR requirements. So they are not ready to detect and respond to outbreaks, let alone to report it to WHO within 2 to 3 days. So that resulted in the genesis of global health security. When it was first initiated in 2014, 2015, GHS was designed to help countries establish the capacities that are needed to meet the IHR requirements. And global security was championed because, as you know, diseases spread faster and affect the world community within a short period of time. It also made a lot of common sense economically, because epidemics and pandemics cause significant morbidity and mortality, as you know, but they also cause major disruptions in the global economy. Now, as you can see from the slide, global epidemics have a very high price tag. These are examples of the costs associated with past epidemics and estimates for the COVID-19 pandemic. As you know, the pandemic is not over yet, but in general, the epidemics that we've been grappling with in the last several years have been very, very costly in terms of human life, animals, but also the world economy. So global security was very imperative to try to bolster the capacity in many countries to be able to address emerging health threats. Now, CDC works in over 60 countries. In the division that I represent, Division of Global Health Protection, we have staff on the ground in 30 countries that are shown on this map. And when global security was first developed, we had different technical areas that are outlined on this slide. CDC has implemented global security programs in some of these technical areas, and we have partnered with Go High in some of these technical areas, including antimicrobial resistance, zoonotic diseases, surveillance in laboratory systems, particularly in East African countries. So these technical areas are championed in many different countries, and funding has been provided by CDC and other USG partners, such as USAID. My division focuses on strengthening capabilities in these four, what we call essential technical areas, shown on the slide. The functioning of these core areas are identified as very critical for the detection and response to novel outbreaks, so that countries would be able to meet the IHR requirements. Any weak link between these can lead to a breakdown of a well-functioning public health system. And I don't have time to go into a lot of details in these. And at the core of all these four is basically zoonotic diseases, because zoonotic diseases, as you know, constitute the majority of the emerging infectious disease, emerging pandemics and epidemics in the past. As part of the global health security agenda, the US government, including CDC, has committed to provide direct support to 19 priority countries that are shown on this map. These countries are selected for intensive GHS implementation in the technical areas that I showed in previous slides. And a lot of funding has been devoted to working on global security in those technical areas. This what we call 19 intensive GHS intensive countries. As I said, Go High had helped us implement some of these projects in Ethiopia and East African countries. GHS implementation is not just handled by CDC, it's a US government effort. Various agencies that are listed on this slide have different roles, and the initiative has been embraced by other donor countries, particularly in Europe, in some Asian countries, including Japan and South Korea. Since it was first initiated in 2015, the US government had invested up to $2 billion on global security, particularly in the 19 countries that I outlined in the previous slide. In fiscal year 2020, right at the time when COVID-19 started, the US government has provided close to $500 million to advance global security in partnering countries. In this fiscal year that just ended, in fiscal year 21, the Congress had appropriated over $600 million for capacity building in the various global security technical areas in the 19 countries. Part of the GHS implementation is evaluation of the program impact in the progress we're making around global security. IHR has its own assessment, a core assessment, and it's a self-assessment by countries, but we work with WHO to develop what we call a joint external evaluation to help countries identify gaps in the global health security technical areas and leverage the resources that are available within and outside of those countries to address those gaps. The joint external evaluation is an extensive evaluation, has different domains, and is done by a team of experts assembled by WHO who travel to a specific country and do an extensive assessment and identify those gaps. To date, 113 countries shown on the map in the green have completed their joint external evaluation assessment. This is, as I said, it's a validated assessment done by a team of outside experts coming from outside of that particular country. So we set a target that by 2024, at least 100 countries will build what we call demonstrated capacity for GHS in numerous GHS target areas. This slide shows the progress to date based on joint external evaluations. So our goal by 2024 is to have 100 countries meet most of the GHS target areas. But as you can see, we've been making progress through 2019, and there are evaluations that are currently ongoing in 2021. And as I said, the idea is for at least 100 countries to meet a demonstrable capacity as evidenced by JEE evaluations. Now, I'll switch gears and talk about what's in the future for global security. For the second time, I'll close my remarks on this slide and open it for question and answers. But the phrase, as shown on this slide, the phrase cycle of panic and neglect was coined by the World Bank to describe an emergency response in which resources are used to respond to the immediate health emergency, and the level of effort is not maintained after the acute emergency subsides. So an emergency happens, everybody jumps on it, the way we did in Ebola, for example, in West Africa. A lot of resources are spent, and then once the emergency subsides, there's no sustainability for that funding. And they call that the cycle of panic and neglect. In the future, the plan through global security is to break that cycle. One approach is to create what we call a global health security financial intermediary fund. This is being championed by the US government. It was used to address the COVID-19 pandemic. And there's a plan to extend that financial intermediary fund to global security going forward. So a pot of money will be available to address emergencies, but also maintain the core capacities that are required to address future health threats. For the COVID-19 pandemic, about $250 million was pledged by the Biden administration for the Financial Intermediary Fund. And an additional $850 million has been requested from Congress. And the last thing, obviously, that we need to do is to learn from the COVID-19 pandemic and try to build a more resilient systems based on the lessons that we learned from the strength in responding, but also the deficiencies with the COVID-19 pandemic. And there have been, as you can imagine, a lot of deficiencies related to our response to the COVID-19 pandemic. There are groups trying to identify those lessons learned to be able to apply them and incorporate those points in the global security agenda going forward. I'll stop there and open it up for discussions. Back to you, Wondwossen.
Excellent. Thank you so much, Ermias. This is wonderful. Another very complimentary talk and very important highlights. I'm sure many of you in the audience, many things come to your mind in terms of how the world should be, better be prepared in the future, epidemics or pandemic situations. From we have to shift from this very costly reactive approach into a proactive, reasonable one. Especially one of the slides Ermias showed in terms of 12 trillion in past on COVID-19, which is not even over yet. Imagine that if the world was better prepared, capacity was built much in advance. I remember reading 2018 or so, World Bank report, Frank Bert and the team, I think, published that, and I've been using that in my various presentations with proactive approach, where in that, prevention of pandemics, it may cost 3 to 4 billion or something like that was the World Bank's estimate. But, mitigating is much, much, much more expensive. And that's among many points you made, Ermias. So thank you so much. And thank you, and CDC. So we'll move on to Amanda, Resolve. So Amanda, please go ahead.
Hi, good morning and good afternoon to everyone, and thank you so much for the opportunity to share some of the work that Resolve to Save Lives has been doing with many of the partners on the call, including actually everyone on the call to some extent. So I'm going to build off the CDC presentation, especially around the work around the IHR. It's the main framework that we use at Resolve to work with countries to build stronger health security systems. And so as we outlined, the world wasn't ready for COVID-19. As we know, many countries remain unprepared. This is a map showing the results we saw in the CDC presentation, a number of countries that had done the JEE. And this slide represents the scores from those JEEs. So those green countries indicating countries with more preparedness, and the red indicating countries that were assessed as not ready or less prepared. But as you can see across the map, some of the countries that are in green, including the US and to some extent Australia, didn't fare very well during COVID. And so the main takeaway here is that no country was fully prepared and everyone still has work to do. So at Resolve to Save Lives, we've been working with funding from the Gates Foundation, as well as the Chan Zuckerberg Initiative and the Bloomberg Foundation, to really focus on working with countries to build health security systems using those joint external evaluations, which include One Health and Human Health and the interface. So we support, similar to CDC, across those 4 key areas, but we also see a really important aspect of legal support. It became very clear during COVID that legal mandates and public health law were essential, and that enabling environment to help health security is critical. Also rapid response funds and protecting healthcare workers, which up until now hadn't been part of the JEE, but is in the new revision actually that is being undertaken by WHO at the moment. So similar to the slide we saw for CDC, the absolute cost at the moment, the IMF is estimating that COVID will eventually cost $22 trillion, which is that large orange square there. And as we saw in the last presentation, it doesn't need a very, very big outbreak to cost a lot of money. SARS at 40 billion, H5N1 at 40 billion, Ebola 55. We worked with Georgetown University to estimate what the cost of getting countries ready under IHR would be, and working with them on costing out what getting countries to green, increasing their capacity using the JEE would cost, comes out at about 113 billion, which is that blue square there. So not a lot of money, as we've said, the return on investment, 113 billion against 22 trillion. Is an easy return on investment case to make, but we have been in that cycle of panic and neglect. And after every outbreak, including SARS and MERS, we've had a greater call to action that has petered out. And so the emphasis for us really now is to make sure that that doesn't happen again. And the fifth that we spoke about was one of those opportunities. So if we look at what that 113 billion over 5 years is how it breaks down, it's about $3 per person, $3.20 per person. A large amount of that money is needed in the first year, about $27 billion, and spread over 5 years to build capacity. And a lot of that money is going into the prevent and detect space, especially around the zoonosis piece, but very heavily also on surveillance, lab, and workforce. So when we started to look at how we can apply the funding available, and there has been money available for health security in the past, one of the challenges has been building individual capacities using the joint external evaluation. You can see on the left there, the red and yellow colors indicating the scores per country, per technical area. And essentially countries have been building blocks or capacities system by system, lab support or surveillance support. But when we looked at how the systems need to work together, including animal and human health, but surveillance and lab, as well as response, the map of system strengthening actually looks like the systems map on the right. Everything needs to be connected and work together. And so this has really changed our approach in terms of how we try to leverage global funding, where we make our own investments, and how we provide technical support to countries. So we really work with countries to, similar to CDC's approach, use the JEE as that core assessment tool, help them create costed plans so that we know how much it's going to cost, work with them to get those plans financed, either through IDA funds at the World Bank, other philanthropy donors. We provide some funding ourselves. And we've been working with countries like Nigeria and Senegal to leverage domestic budget lines to really help countries step up and improve their baseline. But stepping up only gets us part of the way there. So being ready on paper, ticking the boxes on the JEE doesn't necessarily equal strong and real-time performance. And that's what we've seen, for an example, in the US, where they scored very, very well on the JEE, but not necessarily performed well during COVID. A country's ability to detect and respond early to infectious disease really requires a review of how all the elements of global health security system work together in real life scenarios. And so at Resolve, we're promoting two new approaches that are working very well for us on the ground. One is a combination of technical support, operational support, and generating political will. And the other is timeliness metrics. So the first one, just to dig in there a little bit, what we realized was there was a reasonable amount of money from the World Bank after Ebola, part of a multi-country project that addressed One Health needs, both animal, human, and environment. About $700 million on the table across, I think it was eight countries. But that money was stuck. Countries had access to the money. They had the JEEs to create plans, but the World Bank plans and the WHO plans didn't align. There was a lot of paperwork and bureaucracy to move that money. And so as we worked with countries on the ground, we realized that they needed support in technical rigor, but there was a lot of expertise around surveillance and emergency operations centers lab on the ground. Where the real bottleneck was operational excellence, the ability to plan and implement multi-sectorial large-scale programs, and the political will and accountability from senior management in the different ministries. And so we've really worked with a number of countries to build this top approach. We run project management training across 9 countries. We work on advocacy at a local level, but also governance and accountability structures, including the One Health platform, to really make sure that we have these 3 legs of the stool, so to speak. And we find if we get all 3 of those right, actually implementation for preparedness accelerates quite quickly. But the list of things that we need to do is quite long. In the first 100 JEEs, more than 7,000 gaps in capacity were identified. And so no country, no matter the operational excellence or the political will, can move 500 to 700 activities at once. And so there's a need to help countries really prioritize and focus on what makes a difference for them and what makes a difference for the epidemics and the endemic diseases with epidemic potential that they face every day. And so we've been working with countries to use a metric, a timeliness metric, that allows countries to benchmark their performance and really identify bottlenecks in those critical first days of early detection and early response. So we've put out a call for a global goal called 717, that every country should be able to detect an outbreak within 7 days, including animal outbreaks, should be able to notify that outbreak according to IHR legislation for 1 day, and be able to start an effective response in the first 7 days. So it's an achievable but ambitious goal. And we've done a number of retrospective surveys on this. There's been some research and analysis on timeliness metrics in the past. WHO Afro analysed 240 outbreaks over a 5-year period. And a number of those outbreaks met these targets. Some of them were just out of it. But essentially, we feel that this is a realistic goal for countries to push for. And we think it creates an environment of global governance and accountability that we haven't really had. We got a lot of momentum after JEEs. It really supported a focus on health security, but it's hard to explain 19 technical areas with lots of different capacity scores. It doesn't necessarily always translate into real world performance. And so we looked at other health initiatives that had galvanized global support and been able to accelerate progress. And one of the best examples of that was the United Nations global goal for HIV, known as 90-90-90. And so these simplified targets that really hold governments and partners to account are easy to explain, but translate into real world capacities, we think is a real opportunity to help us accelerate and make the most of the new funding that's coming down, including from the FIF that CDC mentioned. And so working on the 717 framework, it requires that we improve a number of aspects, including that watch function. And this is where some of the One Health work really needs to be strengthened, especially around the surveillance and early detection, so that we're thinking about situational awareness and early detection, especially at community level, building trust with communities so that we can identify outbreaks early, that we have the resources to investigate those outbreaks quickly. Several of our projects include rapid response funds, which essentially are very easy to access, low levels of funding, $5,000 to $10,000 to get teams out onto the ground to investigate outbreaks very quickly. In Nigeria, we've been able to reduce the time between an alert and an investigation from 9 days down to 48 hours, which has been a significant improvement for that team. Coordinate response and then use it for quality improvement and continuous improvement, really prioritizing those activities that need to be addressed from the national action plans of health security, helping countries improve their JEE scores and their performance in real world events. So as part of that, the 717 target, we really hope to be able to help countries utilize and prioritize the available funding that they have, really drive ongoing performance improvement activities, and use it to clearly identify where future investments need to be made. And where we think that this is helpful is the JEE has really laid out a roadmap for us around capacities, but it misses sometimes the systems components of good governance, decision-making, clear communication and coordination, where 717 really allows us to assess the bottlenecks, both in the hardware systems, but also the software systems, and be able to invest in those things, including the technical skill, the operational skill, and the political will and decision-making, to give us a more holistic understanding of how the system is performing and really target our future investments, the technical support that's required, and the areas of focus, both for country counterparts that are accountable for this work, and as partners, including Resolve, in terms of where we can support going forward. So at the moment, we have several pilots, 3 supported by the Gates Foundation, 4 of them being implemented by CDC, and 4 of them being implemented by Resolve to Save Lives, really testing this model out on the ground to show how it can help prioritize activities and how we can link it back to funding as we go forward. So I think I'll make sure that we leave plenty of time for questions there and just finish off.
Excellent. Thank you so much, Amanda. That's wonderful. All wonderful, points you raised in terms of the cost and how the world should focus on the technical, operational, political, which is highly important. And I think we often feel as a scientist, we have a long way to go convincing politicians on embracing, leave alone One Health, or embracing the many priorities, around One Health and other areas, and investment in a proactive way, which is really the key emphasis of today's panel. So thank you so much, Amanda. I would like to remind all the audience in the room, please, type in your questions in the Q&A, or if you are really interested to speak, please, let us know the Q&A, and I would allow you to speak. So, okay, Dr. Laura Binkley, come on video, please, especially the panelists, but anyone is available.
Hi, thank you. Thank you for your wonderful presentations. And thank you for all that you do for providing these opportunities for us to carry out this important One Health work. So I noticed one priority area that was mentioned was surveillance and detection. We know that roughly 60% of emerging infectious diseases are zoonotic, and about 71% of those originate in wildlife populations. However, there still seem to be some limitations surrounding funding to establish surveillance in wildlife populations. And so I was wondering sort of what recommendations you have to get that sort of work started, and what opportunities may exist.
Okay, who wants to start? So surveillance has been mentioned by many of you. So anyone who wants to jump in, or before?
I can jump in, Wondwossen.
Okay, Ermias, go ahead.
I mean, Laura, thanks for that question, because it's a very, very critical question. In any detection, surveillance, and response activities, usually the weakest link in that system is the animal side, particularly for zoonotic diseases that have the potential to become an epidemic or spread globally. And even within the animal side, the wildlife side is the one that's also more neglected. So that's a very important topic and issue. As part of global security, if you've seen, one of the technical areas is zoonotic diseases. As part of the zoonotic disease technical area, funding could potentially be available for not just the human side, but also the animal side of things. Usually the problem is not only funding not being available for the animal side, but in the countries where this is needed the most, the need to coordinate with the animal side, to coordinate with the human or the public side, is usually non-existent. So agencies that work or focus on wildlife may not even be aware that those opportunities exist. And that's one of the major problems. Yes, most of the funding usually goes to the human side, the public side, and there's a lot of need to bolster the animal side of things, both in surveillance in animals and also in laboratory, including the wildlife. And to try to address this, you're probably familiar with what we've been doing in the GHS countries. We'd come up with a One Health prioritization scheme. So we bring in experts from the human side, the animal side, including the wildlife side, to try to prioritize diseases that all the different sectors could collectively address. And if countries prioritize those diseases, and some countries have already done that, then global security funds could potentially be available to support them.
Thank you.
Excellent.
And I was just going to also note that community level initiatives were also mentioned, and that's something that would also, getting the government sectors to work together is definitely one of the most critical things here. But also getting some community level initiatives started for wildlife surveillance with community animal health workers, that sort of thing would also be something of interest. So I'm very interested in looking at the root causes at transition, and so looking for opportunities there. So thank you very much.
Maybe just to give a quick example, we support project management for the wildlife ministry in Uganda, and they've been able to do a great job of actually prioritizing wildlife surveillance of the gorillas. And it really came because obviously it's a major tourism and economic issue for them, but they had a human case of scabies move from the human population into the gorilla population, which required an infant gorilla to need treatment and actually passed away. And so because of that transmission from the human side to the animal side, rather than the animal side to the human side, actually there's been a big investment of community surveillance around that gorilla population. And so helping governments make the economic case for wildlife surveillance has been able to gain some traction. And as you said, using that community interface, but making sure that the return on investment or opportunity cost for communities is balanced with, often it comes with an economic loss, reduction in access to bushmeat or other financial incentives. And so I think looking at it as systems approach to make sure that you're looking at the economic issues as well as the public health issues on both sides. We've seen some good examples, especially where animal tourism is at the center.
Excellent point. Fully agree.
Yeah, I think more and more investment will be highly needed. In fact, as the history teaches us, in the Ebola and other cases, wildlife remains highly important, but also as a world population, the urban population currently, I think estimated 55%, heading to estimated by 70% of the world population getting urbanized. We are encroaching more and more onto the wildlife ecosystem. So I think it's inevitable that we're going to see more and more of this. So it's a very important area. So thank you. Related to this, and as already responded to by Ermias and Laura commented and Amanda touched, Dr. Linda Saif mentioned in the Q&A. All of you, please type in your questions in the Q&A, not a chat, preferably, please. Linda raised an issue, a similar issue that, working on, besides One Health, how to promote fund in an integrated way, while surveillance in humans concurrently with animals, yes, which is touched now, but often the ministries of health and agriculture do not interact. That's a silo effect we all see across the planet, and we are discussing. So I think it's already answered, Linda, in a way, but increasingly, but part of the global security work we were doing, as Ermias articulated earlier in his presentation, and now Amanda also touched, and almost every agency is already increasingly appreciating is global security is allowing through the JEE, bringing in the multi-ministries, not just even agriculture and health, environment, others, education, science, higher education, others are involved in our case, to bring together these various ministries, to talk to each other, to partner each other, so that they are enabled or capable to tackle problems when epidemics and pandemic occur. So hopefully we see more and more of that. So just in the interest of time, to moving on, there is other questions. Of course, we all know the concept of One Health has been there for a long time. There's no doubt. Even if we didn't call it One Health, Dr. Ebba Abate from Ethiopia is asking this question. He's formerly the Director General of Ethiopian Public Health Institute, currently a technical director at our Global One Health Initiative office in Addis. The concept is there, he mentioned, for a long time before COVID, yes. By the way, for me as a veterinarian from Ethiopia, practicing in Borana pastoral in south of Ethiopia, we were doing One Health at a time, but we never called it One Health. It's not about the book or the concept or somebody mentioned it, but it's been there, particularly in the developing region. The day-to-day life really exhibits One Health in many developing countries. But Ebba's question, Dr. Ebba's question is, do we use the COVID situation as a good opportunity to springboard, lift up the buy-in by the government's financiers to reframe the landscape and financial resource allocation to One Health? Do you think we are achieving this, as a result, at least looking at the silver lining of COVID? He's asking, do you think we are achieving that, the momentum in One Health as a result of COVID increasing? I know your organs are already, we're gearing up, as you said. What do you think? Kristen, let's start with you, and just pointing this, any of you can answer it.
Yeah, I mean, points well made and well taken. And, I do think we're making progress. The pandemic, because of, I think to Amanda's earlier point about the economic costs of the pandemic, it's grabbed the attention beyond what simply, maybe a health cost might otherwise do. So, across ministries, everybody's been affected. Every ministry's been affected. Every sector's been affected. So the attention is heightened right now to pull together to build systems for prevention. We certainly see, a history of deep interest, to Ermias' earlier point too, that kind of panic and reactive mode that comes about. So, to sustain the momentum, we do need new ways of working, and we have to have that cross-sectoral coming together within ministries. It's already been mentioned that, livestock is managed out of Ministry of Agriculture, Ministry of Livestock, completely separately from ministries of health. And when you have national budgets and ministerial budgets that are tight and constrained, it's all about those trade-offs. So using data and evidence, using cost models to advocate for why certain investments in pandemic preparedness and reducing the burden of infectious disease from various sources, from animal sources, from food, from otherwise, are a highly cost-effective intervention, and why that preventative attention is the best way and best place to put your resources is critical. And joining up that conversation and bringing in the Ministry of Finance too. It's not just advocating to the Ministry of Health and how they need to shift and backwards link. But Wondwossen, to your point about you were doing One Health, in practice, but that's from the vet side, right? The veterinarians are leading this charge, and I think too often when we hear the term One Health, it's animal health, right? And then it's compartmentalized, and it's someone else's responsibility. It's not like the health sector's responsibility; it's the animal side, So, bringing in the ministries of health where there's more money and more dollars, and making the case for them why they really need to join up is critical. And I am optimistic. I do think there's momentum there to build these shared services and systems.
Great. Thank you, Kristen. Peter, knowing NIH has so many centers and there is cross collaboration across centers, while silos exist, there's always also horizontal collaboration. You work with a lot with the ministries of health across the planet in many LMIC where NIH funds. Do you see, what is your comment on cross-ministerial as in partner countries that you work with, or what's NIH's thought of this?
Sure. So from the NIH, we often interact with both the ministries of health and the ministries of science and technology, or science, technology, and innovation. So we do see that interface across the ministries. And one of the messages that we've been hearing where we're interacting with our partners, we've had a meeting in Africa a couple of years ago to ask about this issue of having more government and private sector investment. And what we hear is that, heads of state and ministers of finance don't care about people's professional careers as researchers. You're really not interested in the numbers of publications. They want to see either health impact or something that could be spun off as a business or as a source of investment or employment for the people. So that's really changed our views in terms of what we should think about in terms of our metrics, or how we should be selling the concept of investment in R&D. And I've said COVID has really underscored that the countries that have been able to develop their own diagnostics or be able to really have implementation research, they've really benefited from that, and we're seeing more investment around that. I just want to comment that some work that we've been doing in terms of developing these metrics for research capacity. There's now, I don't know if Ermias or Amanda, you're familiar with the Global Health Technology Coalition, and with their leadership and with the leadership of the Ministry of Health in Thailand, have stood up a R&D task force for the global health security agenda, and to really continuing the concept that was promoted by the World Bank and CEPI of having research capacity as an element of pandemic preparedness, that they've now established this R&D task force. And I know it's difficult to add new things to the JEEs or to the global health security agenda priorities, but I'd be interested in your perspective on the prospects for that, of actually adding to the GHSA and to the JEEs some metrics of research capacity and the ability to develop medical countermeasures.
Right. Okay. Very good. Good. Yeah. So yes, definitely highly important and needed areas, regardless of what agencies we work in. It's the multi-sectoral partnership is critical for One Health, no doubt about that. Just to qualify my comment, back in early 1990s, when I was a veterinarian, how we do One Health, I was referring more of, health service delivery in the pastoral areas. I work for the Ministry of Agriculture of Ethiopia, but the Minister of Health, the clinician, the human physician, we call each other, particularly, pastoralists, heavily they attend their animals, less so for their children, kind of unfortunately, but I wish they give the same attention or more to their humans. We are Homo sapiens, so we are selfish for ourselves, but they give attention to their animals. So whenever we arrange a black leg, there are different endemic countries, some Clostridial vaccination campaign, the physician calls me, they tag along with us. We go together. When the pastoralists bring their cattle, they also bring their children. They are all always moving on with their family of cows and children. So when we give black leg vaccination, the physician and nurses, others, they give polio vaccinations there. It's for me, it's a classical One Health care service delivery. We all celebrate, we have a beer or some lunch and we go home. So I always enjoyed that life and always helped me who I am today. So I just want to qualify that. Okay, so I think there is a third question, but I have also some questions from this side, but great questions coming up. Laura, can you read the question for me? Because I have challenges in the Q&A, seeing multiple screens.
So We have some questions. I'll read those that are in the chat.
There's a third question on the chat side. There is animal disease question. The side that one is, I don't think that would be.
Yeah, so the only other question we had was it's a follow-up to the rest of Dr. Ebba's question. So it had cut off. It said, so for the GHSA emanates after 2014, 2015, the Ebola crisis, and has brought significant impact on global health. Do we need to now revise further the use of IHR-JEE and other models based on the experience we see from the COVID-19 pandemic?
Maybe I can jump in and hello to Dr. Ebba. He's correct. The WHO has undertaken a review of the SPAR and the JEE. It'll be coming out to countries in the next 2 weeks. So to reflect on Peter's question also, R&D has come up in that and it's made the larger cut. I think it's been expanded from 49 indicators in the JEE out to 64. Whether all of those indicators make it through to the final round, we will see. There's new areas focusing on infection prevention and control. I think there was a massive gap in the JEE with a focus on frontline healthcare workers, including animal workers, and we've paid the price for that heavily during COVID. Ethiopia actually led the way in a WHO resolution and getting that area into the JEE to protect healthcare workers. The health minister there in Ethiopia drove much of that. So there are lessons learned. I think two concerns from my side, that after Ebola, we pivoted very hard on the lessons learned from Ebola, and we focused on building a lot of the health security systems for Ebola type diseases. We seem to be swinging very hard back to pandemics. We've lost the wording epidemic preparedness. Everyone's focused on pandemic preparedness. They're not necessarily the same things. There's an overlap, obviously. And so there's a real risk that we swing too hard towards the lessons of COVID. And so we're trying very hard to help. We've got lessons from a number of large outbreaks, including Zika and SARS and MERS, but those smaller outbreaks that we see across this, like anthrax, that we need to learn from and build on. So there is a lot of lessons learned work happening at WHO, and countries should start to see the first revisions of the JEE. The panel on IHR has recommended against major revisions of the IHR, but there is a new process that Dr. Tedros has announced called the UHPR, which would be more like an external, like a nuclear UN checklist, where external partners would come and check on capacities at country level. And that technical working group is meeting for the first time next week. So there's a number of new initiatives around IHR and strengthening the assessment tools due to come out. And I would encourage especially the One Health practitioners to make sure that they review those, not just the zoonosis pillar, but where One Health fits more across the board, including the emergency operations centers, the risk communications piece. I think too long One Health has been siloed in that zoonosis pillar, and we need to make sure it's across all of those technical areas, including points of entry where it hasn't been strong enough in terms of trade and travel.
Yeah, thank you so much, Amanda, and other people may have additions, but let me take the opportunity to highlight, traditionally, and to some extent in some organizations, One Health still is heavily, like you said, siloed in the zoonotic diseases. But of course, there is many biological, chemical hazards, and sometimes physical hazards. That's the interface which needs to be a big One Health issues. We, from the outset, as Ohio State Global One Health, embrace a broader definition of One Health, and also in terms of discipline representation. I can tell you, starting from like 2013 when we launched rabies, the role of business MBAs were critical. Nurses like yourself were very critical. Business people came into the picture when we launched it, as Ermias knows very well, rabies prevention and control as a model project. We, veterinarian, physician, others, no idea about supply chain and logistics. How do you market and all that? So the business professionals mapped out great champions and members of the One Health team since then in many regards mapped out the supply chain logistics. Engineering, be it in biomedical, is the obvious one, but also now is unmanned aerial vehicles, other technologies, diagnostic technology has been a key. Communication and social science and sociology has been critical, and many, many others. Of course, agriculture, food, and vector-borne entomologies, others as well. So definitely we have to embrace a broad definition without losing the focus of that interconnectedness of human, animal, plants, and the environment. Okay, so let me just progress a couple of questions. We have 15 minutes left. One question I have is I really want to know, there has been, of course, origins of emerging, either it's acute like communicable diseases, as we see often, could originate from any parts of the planet, or sometimes we have a chronic pandemic. What I refer as a chronic pandemic is antimicrobial resistance, which has been really increasingly becoming a major challenge, and United Nations designated it no longer just as a threat, public health threat, but as a crisis since April of 2019. And it's a broad issue, clearly a One Health issue. But my question is, while we focus on these various issues, and environment and cancer could be One Health issue, we do work in cancer, by the way, in One Health, because environment has a relationship with chronic diseases such as cancer. But in terms of funding investment, and these diseases being global, and some of our audience here are from Brazil, I notice, and our work is also Latin America, Africa, and Asia, of course, starts from United States, Ohio, or Michigan, Texas, other places. We have quite a few projects in Midwest US as well. And my question specifically is, how much of your funding, maybe roughly, is going to the various LMIs, is Africa versus, most of our discussion has been Sub-Saharan Africa, versus Latin America, like Zika virus, highly important issue, but many things. Recently, just before COVID, I was in Sao Paulo, as well as in the northeastern part of relatively the poor part of Brazil, in Paraíba, Pernambuco, Bahia, similar to Sub-Saharan Africa situation, in many diseases originate. And also Asia, a very large population of humans, a large interaction of wildlife and the humans. How much of your resources are allocated in these various places, and what are your thoughts in terms of the allocations from geographic point of view? And Peter, you want to start?
Yeah, sure, Wondwossen. It's great questions, and something that we try to track from Fogarty. As I mentioned in my presentation, we do see very extensive collaborations, and it's really across the globe. It's actually the greatest international collaboration is with the higher income countries. Canada is actually our #1 collaborator, but as a region, it's with Europe where there's the most collaboration. But we do see hundreds or thousands of collaborations in Africa, in Asia, in Latin America. I would encourage you to look at the World Report tool and to really to drill down and see what specific areas that you're interested in and where those collaborations are. One area that is lagging is in the Middle East and Northern Africa. That's really quite underrepresented in terms of the funding and the NIH collaborations, but otherwise across the globe, the Americas, Africa, Asia, there's hundreds or thousands of collaborations going on in each of those regions.
Great, thank you. Other thoughts? CDC is very much global as well, Ermias, and then maybe Gates Foundation. All of you, please, if you tell us from your organization standpoint.
Yeah, so CDC works in 60 countries, basically in all continents, except probably Antarctica, in Oceania. We have country offices in 30 countries. So we have an actual physical presence in 30 countries, including in Latin America, Asia, and in African countries. When it comes to global security, as I showed in the map, what we call intensive support countries are 19, and all of those countries are in Africa and in Asia. There is a plan to add additional countries going forward. That decision has not been made, and that may expand the intensive support countries to other continents, particularly Latin America. There's also on the side a realignment of our global presence at CDC. We're moving towards a regional model. So to Peter's point, we have now opened a regional office in the Middle East. We have in Eastern Asian countries, there is a regional office that just opened up. And we also have a regional office in several African countries that are in the pipeline, but also one in Latin America based in Brazil. So there's that realignment happening. So funds would be directed through that realigned regional structure going forward. Just wanted to point that out.
Great. Thank you so much, Ermias. In terms of Gates Foundation, it's also global, including US, right?
Yeah, we most heavily focus in sub-Saharan Africa and South Asia, but the bulk of our funding, I would say, goes to what we would call global public goods. So, systems and tools and technologies that are relevant across the globe for various purposes related to global health and public health, livestock and otherwise. And we invest in South-South partnerships and otherwise to translate learnings and lessons from one place where we're working quite intensively to other places. For example, we have, while we don't work intensively in China, we have a China country office. We also have an India country office with strategies for India for India, India for the world, and translating things to the region. We also for certain diseases, we essentially follow the disease and invest intensively for things like polio, for example. So, in our drive to eradicate polio, we will invest in countries and go where there are outbreaks where we need to dive in and put deep resources towards the goals that we have. So that's, essentially in a nutshell how we think about these.
I think we may have a connectivity issue on Juan De San's end, but we do have a couple more questions in the Q&A. So I guess we can give Juan De San a few more minutes. If not, I'll go ahead and read.
Sorry, I have technical problem here. So I am back. So sorry, technology. Okay, I almost had everything, Kristen, but my machine failed for some reason. Okay, Amanda, can you quickly address something?
I can go ahead and read. Oh, I'm sorry. Go ahead.
No, I will go very quickly. We're much smaller donor than the other partners, so a lot of our funding is more catalytic. So our implementation focus is very much on Africa. We have some catalytic funding with the Asia Development Bank and the World Bank that supports across Southeast Asia, but the large majority of our investments are in Sub-Saharan Africa.
Okay, excellent. Thank you so much. So definitely great breadth of work. So there is one question from Dr. Linda. Say if Laura read it, and I have one final question. So let's quickly address it. Lots of interesting questions coming up, but definitely wonderful conversation. Laura, can you read on the biorepository?
Yes. Yes, so there are biorepositories or biobanks for human pathogens or sera, but less so for animal pathogens or sera or tissues to retrospectively test for the origin of zoonotic pathogens in various species. Might funding for research or for such repositories be possible since next generation sequencing is now more readily available, as are multiple serology assays?
Okay, this is interesting, I think, for many of you. So jump in, anyone? So maybe Christine, since Kristen, we're doing, recently Gates Foundation with Africa CDC is a pathogen genomics initiative related to that, even though that one's focused in Africa, but it applies to broad answers. Can you start with that? And then NIH as well as CD, there's always biorepository issues and data. Of course, NIH is, NCBI has been the lead for many of us as scientists, but from the implementation side, I don't know if that's, since you mentioned also data, Kristen, I don't know if Gates Foundation is thinking about these issues.
Yeah, absolutely. We are very interested in leveraging genomic sequencing capabilities and strengthening capacity within regional hubs and within countries to leverage this technology for multiple purposes. I mentioned the work that we're supporting at the African CDC across the continent, but also linked to foodborne disease as well. So animal health too. So across the spectrum of the broader definition of One Health, we are invested and excited about that technology and purposes. There's limitations as well as we go in, the ability to bring in tools and supplies, data systems management, ethics around data. It's a very live conversation that we're having at the moment amongst ourselves with partners. And what is the ethical use of this technology, respecting privacy, respecting the desire of governments to manage the narrative around certain diseases, to avoid scares, for example, and just how we can navigate the desire to have transparent global systems to help us kind of, as a global community, come in and react and respond to help, mitigate issues that might come about from their various sources, while also, respecting the needs of countries and people and scientists to be able to manage their own data, to control their own systems and to bring those together. So it's a very, very relevant question and issue.
Great. Thank you so much, Kristen. And good human-animal interface. Your cat is looking for her breakfast maybe times. So one has the day she's supporting you. So thank you so much. So Peter, can you complete, because NIH has a broad interest in one of its institutes focused on this area.
Yeah, sure. So, broadly, Wondwossen, as you know, we have from Fogarty a number of programs, global infectious diseases research training that you're one of our grantees. Also, the ecology of emerging infectious diseases is one of our programs together with NIAID and NSF. And those in particular would look at the human-animal interface, but we've encouraged training of veterinarians as part of our research enterprise. And I would just encourage the audience, if interested, to subscribe to our funding newsletter to really have a picture of what's coming up in terms of funding availability for this research. We really at the NIH are focused on human health, but where there is implications for human health and animal health, or the human-animal interface, there are resources and funding available.
Great, thank you. I think with that, let's wrap up. It's 10:29, so I know you all have many commitments. Thank you all so much. This has been really wonderful conversation. There are different questions I have and other people have, but we have lots of other opportunities to follow up much, but thank you so much for your time. It's really been great, great morning, and for some of you afternoon and evening, so we appreciate it.
Thank you so much.
Thank you,
Thank you
Laura.
for the opportunity.
Thank you.
Bye-bye.